Welcome back to the Developmental Medicine and Child Neurology video podcast series. I'm William Graf, a child neurologist at Connecticut Children's in the United States. Together with Leon Epstein from Lurie Children's Hospital in Chicago and Matt Kirshen from the Children's Hospital of Philadelphia, we wrote an invited review entitled Use of Neurological Criteria to Declare Death in Children. Brain death, or death by neurological criteria, are terms that we use synonymously in our review. Brain death is a difficult topic, especially in infants and children. The pain of grief for parents is unimaginable. Brain death in children is also the most difficult diagnosis that a physician faces. Brain death occurs in approximately 1/5 of pediatric ICU deaths, most often after a sudden, unexpected, severe traumatic or hypoxic ischemic event. The accurate determination of death is a necessary responsibility of the medical profession. The topic of brain death has multiple dimensions. Its medical determination includes a technical side with the use of standardized checklists to document specific findings. The topic of brain death also includes another side with many controversies about its biological, philosophical, and legal definitions. In our review, we discussed the technical issues as well as the ongoing controversies surrounding the medical definition of brain death and its legal declaration. Nevertheless, brain death has been a medically accepted and legally recognized definition of death in most countries over the last half-century. Clinical definitions of brain death emphasize the permanent loss of integrated brain function, including the capacity for consciousness, brainstem reflexes, and the ability to breathe spontaneously. Over the last few years, there have been new initiatives to standardize the brain death evaluation process in both adults and pediatrics. For example, in 2020, the World Brain Death Project created valuable educational tools for all physicians dealing with brain death. The World Brain Death Project also recognized continuing inconsistencies in the legal aspects of brain death declaration between jurisdictions within countries such as the United States and between individual countries throughout the world. Between 2020 and 2023, the Uniform Law Commission Study and Drafting Committee attempted, but failed, to revise the Uniform Determination of Death Act, or UDDA, which became a model statute for the last 40 years. The main issues considered in revision of the UDDA was whether the phrase, all functions of the entire brain, including the brainstem, should be changed. Some people argue that the absence of diabetes insipidus indicates the persistence of some brain function in many individuals who would otherwise meet the accepted medical standards for brain death. The concern is that the medical standards used to determine brain death and the legal criteria are not aligned. In 2023, updated consensus guidelines for brain death were published from the American Academy of Neurology, the American Academy of Paediatrics, the Child Neurology Society, and the Society of Critical Care Medicine. In addition, largely similar Canadian consensus guidelines, endorsed by 15 Canadian societies, associations, and consortia, were also published. The primary aim of our review was to summarize these updated consensus guidelines. The new guidelines were created using newly created evidence informed by the modified Delphi consensus process. These guidelines comprise 85 recommendations. The guidelines emphasize a conservative approach to avoid any false positive determination. The guidelines address general principles for the evaluation, prerequisites, special components of the neurological examination, apnea testing, ancillary testing, special considerations, and the professional qualifications to perform a brain death evaluation. Here, we will not discuss the technical aspects of the neurological examination or apnea testing, but we would like to emphasize a few of the main recommendations such as the observation period, prerequisites, and the use of ancillary testing. Prior to conducting a brain death evaluation, the new guidelines emphasize the necessary observation period should be sufficient to determine permanent loss of function of the brain as a whole due to an identified etiology leading to coma, absent brainstem reflexes, and lack of spontaneous breathing. The time to observe for permanency depends on the mechanism of brain injury and age. For example, for infants 37 weeks corrected gestational age to age 24 months, it is necessary to observe for at least 48 hours prior to conducting a brain death evaluation. For adults with hypoxic ischemic injury, it is necessary to observe for at least 24 hours prior to conducting brain death evaluations. For pediatric patients with hypoxic ischemic injury, it is necessary to observe for at least 48 hours. After any medical or surgical intervention to decrease intracranial pressure, it is necessary to wait enough time to ensure that there is no recovery of function prior to conducting a brain death evaluation. The new brain death guidelines make recommendations to avoid inaccurate determinations due to hypothermia, hypotension, or persistent effects from severe metabolic acid base or endocrine abnormalities. The minimum temperature for brain death evaluation is 36 degrees Celsius. The minimum blood pressure is a systolic of 100 millimeters mercury in adults and a mean arterial pressure of 75, with equivalent age-related norms in infancy and childhood. The guidelines also emphasize the importance of avoiding an inaccurate determination because of medication or neuromuscular blockade. The new brain death guidelines indicate when to perform ancillary testing, with the caveat that ancillary testing should only be performed when the entire brain death neurological examination or apnea test cannot be completed and the findings cannot be adequately interpreted. Examples include an inability to correct metabolic abnormalities, but the exam and apnea test are consistent with brain death, then the ancillary testing may be indicated. Ancillary testing may be indicated if there is an inability to perform components of the neurological examination or apnea test because of a medical or surgical condition such as a neck or facial injury, or the inability to interpret whether exam findings are spinally mediated. Ancillary testing may be indicated if there is an inability to complete the apnea test due to instability or suspicion of chronic hypercarbia. Ancillary testing should not be performed in lieu of any testable element of the brain evaluation. The entire brain death evaluation should be fully performed if possible, and findings must be consistent with brain death prior to considering ancillary testing. Ancillary testing should not be performed if any findings on the brain death examination or apnea test are consistent with brain-mediated activity. Ancillary testing should not be used to bypass the strict prerequisite requirements. In addition, the new brain death guidelines emphasize that ancillary testing is not indicated because of the presence of an open fontanelle or a skull fracture or a CSF diversion device. The 3 accepted ancillary tests included in the guidelines are a 4-vessel catheter angiography, radionuclide perfusion scintigraphy, and transcranial Doppler ultrasound in adults only. e.g., auditory evoked potentials and SSEPs are not recommended as ancillary tests in brain death determination. Physicians performing a brain death evaluation must be qualified based on adequate training and competency and performance of the evaluation in accordance with local laws and institutional standards. The medical profession needs to guarantee 100% accuracy in brain death determination 100% of the time. In our review, we also discussed the remaining controversies of the medical aspects of brain death determination and the legal aspects of brain death declaration, with a focus on infants and children. We stress the importance of clear and consistent guidelines, ongoing dialogue between medical and legal communities, and the ethical and legal implications associated with brain death or death by neurological criteria. Different countries, jurisdictions, and medical organizations still have varying guidelines and criteria. Brain death may challenge traditional concepts of death and raise philosophical and ethical questions about the importance of personhood. The goal in achieving uniform international standards is to avoid the possibility that a child could be considered dead in one hospital but potentially alive in another. We also reviewed issues and controversies surrounding the accuracy of brain death determination, religious and cultural perspectives on brain death, and the emotional impact on families after the declaration of brain death in a child. We discussed the ongoing controversies surrounding residual somatic functions after formal brain death declaration, including residual neuroendocrine function, the concept of permanency, and consent. We emphasized the crucial concepts of practice consistency and the prevention of false positive brain death determination. Brain death has a profound emotional impact on families, especially when it involves children. We address the need for social, cultural sensitivity and appropriate, transparent communication with families during the brain death evaluation. Lastly, we provide guidance for brain death accommodation requests. Thank you for your interest in this discussion on the topic of brain death.